So, good evening, all the aspirants, or more aspirants will be joining us. So, today we have the class on cardiovascular disease. It's a CCS session which will be taken by Dr. Varun Pushkarna, sir. He is a senior consultant internal medicine at Fortis Escortis Hospital, Amritsar. So, you may take over. Thank you.
Yeah, thank you. So, good evening, students. We will be having a case, and probably, if time permits us, we'll discuss another case which is very close to my heart, and it is also very important. So, we will begin with this case is the infernal MI. We usually see that usually there is this one patient of uh, acute myocardial infarction that takes us through almost all the stages of management of a patient who is admitted to you with myocardial infarction. So we will try to go step by step, trying to manage as and when the situation arises, and we will have an interactive session. So may I know how many students are there today, Sana? So we have 10 participants, out of which 8, 7. All right. Doctors, I would like to have you all on the board. So at the end of this session, you should be able to identify, to recognize and manage the combinations of as and when they arise. Try to teach them, then try to manage according to the severity of the situation. So, be it arrhythmia, be it complications. So, these are the important things required from when you are appearing in an EDIC examination. I hope the screen is clear and visible to you. So we have a 58-year-old male who has dyslipidemia. You can advocate who is in the department with chest pain radiating to left arm with sweating and vomiting. Now, if this patient presents to you in the emergency room, I will have 3 questions for you. Number 1, what are your initial 3 priorities in this patient? Number 2, if you are suspecting an MI, what biomarkers are you going to order? What ECG findings do you expect? And what ECG findings do you expect to confirm a STEMI? The third thing that I would like to know from you is what would you do if this patient has a STEMI? Would you thrombolize or would you proceed to PCI? So any one of you can turn on your mic. You can tell me, think, it is only that opinion. What are your priorities? Diabetic, dyslipidemic, chronic smoker, 50-year-old male, chest, idiot, arm, 10 on scale, and 1.
Okay, sir. For me, my initial 3 priorities would include having an urgent ECG and then collect blood samples and set for estimation of the cardiac biomarkers, and then resuscitation with oxygen and analgesia.
Anything else? So when all of you are appearing in EDIC exam.
Yes.
So you must start with ABC.
Okay, sir. Noted.
These are your first 3 priorities. Everything else can wait. But ABCs must discuss. Whenever you say ECG, make a habit of saying that the acute coronary syndrome into unstable angina, then non-STEMI and STEMI. So can you tell me the difference between unstable angina and STEMI, non-STEMI? or myocardial infarction and unstable angina? Anyone? What is the difference between unstable angina and myocardial infarction? This is a
Okay,
very important
let me
question.
try. Yeah. In
Yes, go on.
in NSTEMI, the patient presents with a classical chest pain of acute coronary syndrome, which occurs at rest. But the
Wonderful.
ECG will be normal.
Wonderful.
Will be normal, and then cardiac biomarkers may not be elevated.
So chest pain can be absolutely correct. So chest pain can be classified into unstable angina and MI based on, because both of them may have ECG changes. Both of them can have ECG changes, but the biomarkers, they will be absent in case of unstable angina, and MI means infarction. Infarction means release of troponins and CPK-MB into circulation, myoglobin into circulation. In unstable angina, it's crying out of help because the circulation is not enough. So if the patient has an ST elevation MI, then you would consider thrombolizing the patient if the nearest PCI center is 120 minutes away. So you'll thrombolize it. In case you have a system in your own hospital, then you do a primary PCI.
Well, sir,
So we'll
sorry to
move on to the
interrupt,
next
but
slide. The assessment
hello.
is what priorities should.
Sir, sorry to interrupt, but I believe that we
Yes.
are facing some technical problem. Actually, sir, your voice is breaking a lot. I think there is some network issue.
Okay. Okay. Let me see what I can do. Am I audible now? Hi, Sana.
Yes, sir, you are. It's better.
It's better, right? So the first priorities are, number one is to get your ABCs. Hello.
Yes, sir. Yes, sir, we are still having some problem.
Okay, because from here the networking is excellent. I don't know where the issue is. I'm having a very good signal here.
Okay, sir.
Everything is
Okay, sir, you may
fine.
continue.
Yeah. Okay. So place continuous cardiac monitoring, that is with an ECG. Maybe if the patient is going into shock, arterial BP monitoring. Administer only if the saturation is less than 90%. Then immediately move to rapid diagnosis of STEMI and non-STEMI. Get a 12 lead ECG as fast as possible. Look for ST elevation. It carries maximum marks in the ECG. If you see a new onset LBBP or any dynamic changes, for example, T waves getting inverted, the ST starting to go up, rocket like T wave, tall T waves. So these are all hyper, tall T waves. They can be present. Then, of course, send cardiac biomarkers like troponin I, troponin T, and then get a bedside echocardiography. So these are the most important things that you can do to diagnose a patient of STEMI, non-STEMI. Basically, the problem that we keep facing is whenever the patient comes to the emergency room or even in the ICU, the patient has chest pain. The immediate thing that we need to decipher is that whether this chest pain is due to a heart attack or not. If it is a myocardial infarction that is happening and you miss it, it is, it is not expected of an intensivist. So the chest pain has to be followed into an algorithm immediately after confirming your ABCs, you need to get the ECG done, the biomarkers done, and yes, the serial ECGs also have an importance. If something is not shown in the first ECG, repeat the ECG after 30 minutes if the chest pain is ongoing. Of course, analgesia is very important. Giving morphine is, is a good thing to do. Immediately give it. These are the few drugs that are expected from you to know. It is by the mnemonic of MONAS. So M is morphine, O is oxygen, N is nitrates, A is aspirin, and S is statins. So this is the bare minimum that you need to give, along with an anticoagulation, that is low molecular weight heparin. So these are the time critical therapies that should be given to the patient who has come to you with suspected myocardial infarction. If the patient has a STEMI confirmed, then you should activate the cath lab as soon as possible. The door to needle time has to be less than 90 minutes, and this the ballooning process should be finished within 2 hours. That is 120 minutes. If you suspect that the nearest center is far away, it's like beyond 2 hours of distance of traveling, that the patient may not reach the center in 2 hours, then thrombolizing the patient will become a priority. So the loading doses of aspirin 300 milligrams along with the P2Y12 inhibitor, that is either clopidogrel or a ticagrelor, should be given. This is known as a DAPT, dual antiplatelet therapy, plus a statin along with a heparin or low molecular weight heparin. Nitrates are indicated if the blood pressure is more than 90 and patient does not have an inferior wall MI. In our case, the patient has an anterior wall MI and the patient is having ongoing chest pain. So either NTG infusion along with a heparin infusion can also be given. That is based on the discretion of the treating doctor. If they feel that the blood pressure is high and the patient has high risk of collapsing, then you can start NTG infusion along with heparin infusion. Important thing to remember is that diagnosis, stabilization, and early reperfusion defines the cornerstone of management of coronary artery disease or ST elevation MI. These are the initial golden minutes of myocardial infarction, and it has been proven time and again that it improves the overall survival. So, what is there in the ECG? Anyone? What is there in the ECG?
There is ST elevation in lead 1 ABL, B1 to B4, and reciprocal changes are seen in lead 2, 3 AVF, and also in lead B6.
Wonderful. So, what do you class? So, as I
So it's
told you,
anterior wall MI, anterior septal MI.
yes. So, very good. So, when we are seeing the ECG changes, the ranking in order of which it should be defined as number one, presence of ST elevation. Second is presence of ST depression. Third is bundle branch blocks. So this is how you should give importance to the ECG changes. So if the ST elevation is present and ST depression is also present, then you should count the ST elevation first. So tell that there is an ST elevation in 1 AVL and V2 to V4, along with reciprocal ST depression in lead 2, 3 AVF and V6, which goes in the without any significant bundle branch block. This goes in the favor of anterior wall STEMI. Now, this patient has anterior wall STEMI. The troponin T was 0.4 on presentation, but within 2 hours, it increased from 0.4 to 3.2. The blood pressure is 90 by 60, heart rate is 110, and patient has cold peripheries. So what is the diagnosis now? Complete diagnosis. So the patient has anterior wall STEMI with shock or hypotension.
I'm fine, thank you.
So the patient was taken up for coronary angiography immediately, and you see that the patient had a 100% occluded LAD here, which was stented, and thankfully now we see a TIMI grade 3 flow in the LAD. So what started as a chest pain and MI due to LAD 100% occlusion, the primary PCI was done, the vessel was opened, and the patient is now stable. What are the complications do you suspect or expect in this patient after the LAD has been opened? Now the stent has been done. Anyone? What complications do you suspect to happen in this patient?
There may be local side hematoma formation, vessel
Where?
injury.
Local side
Where
hematoma
we have
where?
either in the radial artery or femoral artery from where we have gone,
So you should
and
say
post
cannulation site. It's
cannulation site.
yes. What else?
Later on, there can be infection at the cannulation site.
No.
There,
No. Let's forget that.
perfusion
Reperfusion arrhythmia is the biggest hurdle in this case because LAD was 100% occluded. So imagine this is the myocardium. It was undergoing an anaerobic metabolism, that is glycolysis. So there is a lot of lactate accumulated here. The moment you open up the circulation, there will be an influx of oxygen and glucose and everything. And this lactate, it will just infuse into the circulation. And what will happen is immediate arrhythmia will occur. This is called reperfusion arrhythmia. And in a case of anterior wall STEMI, the worst arrhythmia to have is anyone? Polymorphic VT or ventricular fibrillation. Because this can literally undo everything that you have done. You've saved the patient in the emergency, you have tried to build up this patient, you've taken it to the cath lab, you opened up the blood vessel, and then you lose the patient, secondary to a ventricular tachycardia, polymorphic VT, or a ventricular fibrillation. Now this patient was shifted to the ICU, and this is what has happened. What do you see in this? Forget this. I think this is a wrong thing which is mentioned here. What do you see?
the cardiac tamponade may be there,
No.
or hypertension is there.
Just tell me what you see on the
No, not
on the
cardiac
monitor.
arrhythmia. It's
What?
a pulse pressure variation is there in arterial waveform.
No, let's begin with the ECG. What do you see? Number one, you see sinus tachycardia.
Yeah.
Okay, you will be given monitor photos there. So you begin with sinus tachycardia, heart rate of 119. Number two, the patient has hypotension. Don't say shock. Why do I say don't say shock? Anyone? Anyone? Why do I say don't say shock? Shock is defined by
Three things where alter mental status, decrease urine output.
So basically, shock is defined as hypoperfusion secondary to hypotension. So hypoperfusion is manifested as whatever you said just now: altered mentation, decreased urine output, cold clammy peripheries, tachypnea. These are hypoperfusion. So there is hypotension. The blood pressure is 59/44. And yes, you see a pulse volume variation. You see that one pulse is like this, the others are like this. So you call this pulsus alternans, or there is a variable pulse. What do you comment about saturation? How much is the saturation?
Saturation is not recordable.
Not recordable. So what do you think is the problem?
So
Number
due
one,
to hyperperfusion,
yes. So SpO2 cannot be measured because number one, there is no perfusion. Okay. Second, there are cold peripheries. What do you see in the respiratory rate? So the patient is tachypnic. Okay. So this is the monitor. 6 hours later, the patient has BP of 59/44, mottling of the extremities, patient is drowsy, and the lactate has increased to 4.8. What is the diagnosis now?
now he's in shock.
Yes, so he's in shock. What kind of shock is this?
It's a cardiogenic shock. Yeah,
It's a
hypovolemic or cardiogenic shock.
so one is cardiogenic shock, the other is hypovolemic. How will you confirm that this patient has a cardiogenic shock or hypovolemic shock?
In
How will
hypovolemia, there will be, we can see a passive leg raising test, pulse pressure variation, IVC collapsibility,
very good.
and capillary refilling time.
Capillary refilling would be low in both of these shocks because the cardiac output is low. So
In cardiogenic shock, we can in echocardiography, we
very
can
good.
see
So
general
in
size.
echocardiography is important. You can do an echo and check what is wrong with the myocardium. You can see the JVP. If the JVP is elevated, you are dealing with a cardiogenic shock. If the JVP is not elevated, you are dealing with hypovolemic shock.
Yeah.
So very important to say JVP. So when you are discussing these patients, go back to your basics. Like whenever you see a patient, there are 4 vitals, and then you check for pallor, you check for icterus, you check for JVP. So these are, and you check if the patient is using their accessory muscles. Technically, you need to get a echocardiography done. You need to monitor the CVP. You need to monitor the arterial blood pressure, the mean arterial pressure, and you need to monitor the lactate levels. So these are the important things. So but the questions that can be asked here is whether it is a cardiogenic shock or any other shock. How will you confirm if it is a cardiogenic shock or not? What bedside or imaging diagnostic tools that you can use and that they can guide your management now? What strategy would you follow if the patient post primary coronary intervention after 6 hours has developed a cardiogenic shock? What will you use? How will you try to cope up with? When do you consider putting mechanical devices in? So let's go through the questions. So is this cardiogenic shock? Most likely this is cardiogenic shock. So by the definition of ESC shock trial criteria, a systolic blood pressure of less than 90 for more than 30 minutes, or vasopressor need to maintain the map more than 65 millimeters of mercury defines shock, along with clinical signs of hypoperfusion, that is, cold extremities, low urine output, confusion, elevated lactates, all of them are features of shock. So these are very, very important clinical signs. They will ask you again and again. Now, students get negatively marked at this point. The clinical signs of cardiogenic shock are, or basically shock state, that is hypoperfusion, are presence of cold extremities, a poor urine output, presence of altered mental status, and elevated lactate. Never forget. And along with that, once you have, this is hypotension, this is shock, and this is the defining moment, that is cardiac dysfunction established on a echocardiography. So you have an evidence of cardiac dysfunction on echo or hemodynamically. That is when you say that this patient has a cardiogenic shock. You can even use a Swan-Ganz catheter. So using a Swan-Ganz catheter will tell you that CVP is elevated, pulmonary artery wedge pressure is elevated, cardiac output is low, cardiac index is low, and then you can even titrate your doses of inotropes based on the cardiac output and cardiac index. Although Swan-Ganz or pulmonary artery catheter is not recommended to be used in every patient now, but on select basis, you can use the Swan-Ganz in your patient. Rule out other possibilities. Hypovolemia. Unlikely in this case, unless there is a major bleeding, like a patient develops a retroperitoneal hematoma secondary to a up highly, slightly high femoral artery puncture while doing a coronary angiography. Another important diagnosis that should not be missed in a patient who has been taken up for a primary coronary intervention is cardiac tamponade. That is, by mistake or by luck, bad luck, the patient had a rupture of the coronary artery, that is dissection, and there was a bleeding into the pericardium. Or even worst come worst luck is myocardial free wall rupture. So if that happens, then this is the pericardium, this is the heart, and there is a bleeding from the left ventricle and it fills up the pericardium immediately, and this patient lands up into cardiac tamponade. Can anyone tell me what kind of a triad is seen in patients of tamponade?
So, Vex
What?
triad,
Beck's
elevated
triad. Very
JVP,
good. So what is it?
elevated JVP, muffling of heart sounds, and hypertension.
Yes. So elevated JVP, muffled heart sounds, along with elevated JVP. So there are shock state, JVP is elevated, and the heart sounds are muffled. This is the sign of acute cardiac tamponade. It will also have a feature known as pulsus paradoxus. What is pulsus paradoxus?
Respiratory variation of blood pressure more than 10 millimeter mercury.
So that is pulsus paradoxus. That is anything more than 10 millimeter drop in systolic blood pressure on inspiration, that is breathing deep. Along with that, as there is blood in the pericardial cavity, the ECG will also record alternating complexes, that is known as
Pulses,
that is known as electrical alternance.
electrical alternance.
Okay, so that is known as electrical alternance. So we can do all of this with the help of a point of care echocardiography, that is bedside echocardiography. You can check the LV ejection fraction, you can check the wall motion abnormality, you can rule out any pericardial tamponade, you can even see a ventricular septal rupture, you can even see a free wall rupture, and of course you can make out the scar tissue or presence of any intraventricular thrombus in the left ventricle. So echocardiography bedside is one of the most important investigations, and to clear your mind that what you are dealing with. So if it is a cardiogenic shock, you need to have an echocardiography bedside so that you can actually define what you are dealing with. Along with an echocardiogram, you can get a invasive monitoring done to monitor number one CVP, which will be elevated. Number two, pulmonary capillary wedge pressure, which will be elevated and beyond 18 millimeters of mercury, a cardiac index less than 2.2, and a mean arterial pressure of less than 65 millimeters of mercury. So the next question was, what bedside imaging tools will guide your management now? So the most essential tools are POCUS, that is point of care ultrasound or echocardiography. It will tell you about the global versus regional dysfunction, presence of any tamponade or right ventricular strain. Now, right ventricular strain is seen in which kind of condition?
Inferior valve.
Pulmonary embolism. So many times, RV will be flail in inferior wall MI. In pulmonary embolism, it will be under strain. Why? Because the right ventricle is trying to pump blood into the pulmonary artery. Okay. Then valvular complications like papillary muscle rupture, sudden mitral regurgitation. Of course, along with that, you need to put an arterial line for continuous blood pressure medicines and monitor central venous pressure. You can use pulmonary artery catheter on selective basis. It clarifies the volume status versus contractility issue. Getting serial lactate levels, mixed or venous oxygen saturation or a central venous oxygen saturation, ABG, these are all done to assess the perfusion. And of course, a poor man's cardiac output monitor is urine output monitoring. Now, the next question was, what pressor or inotropic strategy will you prefer in this patient? Now, there have been a lot of discussion on whether to use inotropes first or vasopressors first. But by consensus and by all the guidelines and recommendations, the first line agent is norepinephrine. So norepinephrine is the drug of choice in cardiogenic shock. Once the patient is in shock, you start norepinephrine to achieve a blood pressure, mean arterial pressure of more than 65 millimeters of mercury. Now, even if the mean arterial pressure is achieved and the patient continues to have rising lactates, tachypnea persistent, perfusion decreased, so peripheral circulatory failure, then you should add an inotrope like dobutamine. So dobutamine is basically a inodilator. So what will it do? It will basically do increase cardiac contractility and dilate the peripheries. That means decrease the systemic vascular resistance. This will lead to increase in the cardiac output. But because it causes dilatation of the blood vessels, it may cause low blood pressure or hypotension. The starting dose is 2.5 to 5 microgram per kg per minute, not per hour. This question has already come in headache. That what is the starting dose of dobutamine? It is 2.5 to 5 microgram per kg per minute, not per hour. Other alternatives other than dobutamine are milrinone, especially in right ventricular failure or presence of pulmonary hypertension, because is an excellent pulmonary vasodilator. So, due to vasodilatory actions, milrinone is notorious also to cause some amount of hyperlactatemia. So, lactates rise on milrinone. So, after 6 hours, after 6 hours of milrinone, you must check if the patient is developing hyperlactatemia. You should get a ABG done after 6 hours as a mandate. Other drug is a calcium channel drug, which is a levosimendan, may be used in selective centers where their experience with levosimendan is good. Avoid dopamine. You should not use dopamine. It has higher arrhythmia risk in ICU setting, specifically in a patient who has been taken up for a primary PCI. for LAD territory, you should avoid using dopamine initially. Why? Because it will lead to increased arrhythmias. Then avoid pure vasoconstrictors like vasopressin, like phenylephrine. Why? Because they are risk causing coronary vasoconstriction, also worsening ischemia, cardiac muscle. So when do you consider IABP? See, as long as
Sir,
the
your voice
patient's
is breaking.
inotropes are going on and the level stable, this is a, if the inotropes are increasing, lactates are increasing. So as long as the inotropes are working and the lactates are coming down, this is a patient of cardiogenic shock. But imagine if somebody's lactates are increasing, the shock is worsening, urine output is decreasing, tachypnea is worsening, you feel that this patient might go on ventilation. What is it known as then? It is known as a refractory cardiogenic shock because it is now refractory to almost all the therapies that you have given. This is setting the stage for mechanical device intervention. That means now you will need to put in some mechanical support like IABP or LVAD. So if the pressors inotropes are failing and not working, shock is persisting with end organ dysfunction, this is known as refractory cardiogenic shock. Now this patient, you can put an IABP. Earlier it was class 1, now there is a downgrading of that. So IABP is now not favored. However, my personal opinion is whenever the patient is in shock, there is a mitral regurgitation, there is a VSR, you should always go in for a IABP. Whatever the world might say, whatever, because this is all, I think, pharmaceutical run data. If whenever world wants IABP to outshine, now they want people to use more and more of LVAD and Impella devices. That is why they are saying IABP is not good. But believe me, last 18 years I have seen IABP works wonderful, specifically in a case of left ventricular dysfunction. IABP is excellent. So you should consider it whenever there are mechanical complications like a papillary muscle rupture or a VSR. Whenever you are planning to put the patient to surgery, so it is a bridge to recovery or surgery, and whenever moderate support is needed. If IABP is not effective, then you can go for Impella. Impella is basically a motor which is placed here. It takes blood from left ventricle cavity and throws it into the aorta so that it is unloading the left ventricle. As much as it unloads, as much as the left ventricle gets time to heal. So the basic principle of Impella or left ventricular assist device is unloading of the left ventricle. You should consider this in refractory cardiogenic shock with very low ejection fraction, failure of pharmacological support, that is inotropes or vasopressors, and as a bridge to recovery or a bridge to ECMO. So you should always consider mechanical these supports whenever the patient fails to come out of the cardiogenic shock. If the patient continues to deteriorate despite the LVAD, despite the IABP, that is the time when you should start thinking of putting the patient on a veno-arterial ECMO, that is VA ECMO. It is specifically indicated in global cardiac failure where you suspect that it is a reversible kind of a disease, a rising lactate, and in the presence of MODS. So as a few points to remember for your exam is norepinephrine is the drug of choice for cardiogenic shock. Very, very important. Do not use dopamine. It is highly rhythmogenic. You can add dobutamine in case the patient's cardiac output remains low despite norepinephrine. Always use a point of care ultrasound echocardiography by the bedside to define cardiogenic shock, to define the volume status of the patient, to define whether there is a rupture or not. Mechanical support, for example, IABP, for example, LVAD or Impella, for example, ECMO, should not be delayed beyond 3 hours. So, whenever a patient who has already been in shock for 6 hours, now the patient has been started on inotropes, started on vasopressors, does not improve, the cardiogenic shock continues to worsen. This is the stage set for mechanical support systems, including IABP, including LVAD or Impella, and including ECMO. Now, all these devices, be it ECMO, be it LVAD, be it IABP, they are not therapeutic. You should remember always, they are not a treatment. Patient can never go home on these devices. So whatever good they are good to bring the patient out of the shock so that the patient can be treated definitely. That means if the surgery is to be done, or a PTC is to be done, or a valvular surgery is to be done, so these are at best bridge to definitive management. Is that clear? Any doubts? Is that clear?
Yes, it is. Thank you, sir.
Great. So, in our patient who had a anterior wall STEMI, who was taken up for a primary PCI, the LAD was 100% occluded, PTCA was done with a stent, shifted back to ICU, developed cardiogenic shock. We started the patient on NORAD plus dobutamine. We did an echocardiography, and this is what we find on echocardiography. This patient has ejection fraction of only 25% with anterior wall hypokinesia, plus there is a mild MR. Thank God there is a mild MR only. There is mild mitral regurgitation. Along with that, CVP is 16, pulmonary capillary wedge pressure is 24, and mean arterial pressure, as we saw, is close to 50. So norepinephrine is going on. So we added dobutamine. So the dobutamine was started and the mean arterial pressures improved. It is not mentioned how much, but it improved. So whatever started with anterior wall STEMI, a good diagnosis, a primary PCI, LAD stented, and in ICU, the patient developed a cardiogenic shock. Patient started on norepinephrine and dobutamine. The MAP has improved. The urine output has improved. So the patient, we feel, is now, thank God, a bit stable. Now the patient is better. Only in anotropes, the patient is better. Suddenly, what happens? This patient develops this rhythm on the ECG monitor. What is this?
Monomorphic ventricular tachycardia.
You say monomorphic, I see at least 2-3 morphologies. So this is one morphology, this is another morphology, this is another morphology, this is still other morphology, this is still another morphology. So this is polymorphic ventricular tachycardia. So this is a polymorphic ventricular tachycardia. If you look closely enough, you will see that the morphology is changing. Not as fast, but it is changing. So this patient develops polymorphic VT. We give cardiogenic shock twice. So what happens? Why do these patients develop ventricular arrhythmias? What will you do if a patient has developed a ventricular arrhythmia? And what are the role of magnesium amiodarone? What are their pros and what are their cons? So let's discuss now. Now this patient has developed a ventricular tachycardia post MI. So there are 5 big reversible triggers. You must eventually you should learn and rule them out quickly. Immediately, it is reperfusion injury or ischemia, which is the most common cause of post-MI ventricular tachycardia. Second is electrolyte disturbance. These patients are put on diuretics. So they patients can have low potassium, low magnesium, low calcium. So these are very important. If the potassium is less than 3.5, this patient can develop atrial fibrillation, atrial flutter, ventricular tachycardia, flutter, ventricular fibrillation, all of them can happen. And these patients may have acidosis secondary to cardiogenic shock. So cardiogenic shock will lead to acidosis, lactate will be high, and this acidosis primes the heart to develop arrhythmia. Along with that, third most important trigger is drugs. So Q3 prolonging drugs. Sometimes these patients are on fluoroquinolones. Agitated patients can be on haloperidol. So these are important drugs that should never be given. Or if they are already going on, you should stop them in a case of ventricular arrhythmias. Fourth is hypoxia and volume overload. See, your patient is in cardiogenic shock. There is a peripheral circulatory failure. You have started the patient on norepinephrine and dobutamine in an effort to get the circulation back and running. But as you yourself told, the mental confusion, altered mental status is one of the diagnostic criteria for onset of shock. The basic etiology of why altered mental status occurs is hypoxia, is unable to meet the cerebral oxygen demand. So whenever that happens, or the patient is in volume overload, supposedly patient was in cardiogenic shock and the resident on duty did not know the ejection fraction or did not know how to manage a cardiogenic shock patient, he has given 5 boluses of 200 ml of fluid. So what has he done is he has pushed the patient into fluid overload. So this is another one of the most important reasons. So hypoxia causes less threshold for ventricular arrhythmias. And what about volume overload? Can anyone tell me how volume overload causes ventricular arrhythmias? Anyone can volunteer and tell how volume overload will cause ventricular arrhythmia? Any idea?
Volume overload. Let me try. I
Yeah.
know that volume overload is not good for any tissues because when there is volume overload, there is usually tissue edema, which also turns out to increase intratissue pressure, and the blood flow to the cells are reduced. So which also causes some relative tissue hypoxia, which can lower the threshold for these arrhythmias.
Great. So one is the intracellular edema. Am I right? This is what you were referring to?
Yeah.
So intracellular edema, because it leads to changes in the sodium and potassium levels inside and outside the cells. It can cause that. But at the same time, we know the Starling's forces. So Starling forces are the left ventricle can take a stretch up to an extent. But if it is an infarcted ventricle, it dilates even more. So a dilated infarct. So what has happened is this thinned out portion is very sensitive to stretch. So what will happen is the moment the left ventricle stretches beyond a certain level, this infarct tissue will throw a ventricular arrhythmia. Okay?
Yeah.
So this cannot take any strain on it because it is a dead muscle. It cannot take any strain. So when you try to stretch a dead muscle, it will throw electrical impulses right and left, which will lead to scar arrhythmia. That is called a scar arrhythmia. So VT can happen from a ventricular scar. So these are the major features: ischemia, electrolyte imbalance, acidosis. One is ischemia, second is electrolyte, third is acidosis, fourth is drugs, and fifth is hypoxia and volume overload, which are the five big reversible triggers for ventricular tachycardia. So always get your electrolytes, keep your potassium more than 4, magnesium more than 2. ABG should always be corrected because any moment it can lead to arrhythmia. Keep doing ECGs in ICU as much as possible so that you do not miss a prolonging QTC. And of course, if you are suspecting a reinfarction inside the hospital, then do a troponin or CPKMB. If I have to do either of them, either a troponin or a CPKMB, what should I prefer to diagnose an in-hospital MI?
CPMB, sir.
Why?
So its half-life is less than top I, sir.
So trop I will be elevated till 14 days. So drops will be elevated for 14 days, but CPKMB will come down within less than 4 days. So if the patient has developed an in-hospital MI, the trop T will still be elevated, but CPKMB, if it rises again, this means the patient developed a within the hospital myocardial infarction. Very good. So, when to use antiarrhythmics versus ICD or pacing? So, the rule of thumb is if the patient has shock or hypotension, you always give a defibrillation. So, you always do a defibrillation. If the patient has a stable or non-sustained VT, then you can use antiarrhythmics. So first line for sustained VT/VF after the DC shock. Once you have given the DC shock, then you should give antiarrhythmics. What antiarrhythmics? Amiodarone is the drug of choice. 300 milligram IV bolus, then 900 milligram over 24 hours. If amiodarone is not available, then lidocaine, especially ischemic VT, 1 milligram per kg bolus. How much is the lidocaine in the vial per ml?
So 20 milligram per.
So that means you will need to give around 60 to 80 milligrams, that is 3 to 4 mLs of lidocaine
Of
IV.
2%.
Say again?
That's 3 to 4 mils of 2% plain
Yes.
lidocaine.
Yes, absolutely. So what are the indications? Again, recurrent VT/VF post-MI, after defibrillation in polymorphic ventricular tachycardia, hemodynamically unstable sustained VT where you have defibrillated the patient again and again, and you need to do something more, then you can give antiarrhythmics. There is something known as an overdrive pacing. Now, what happens is these ventricular arrhythmias, they are, they can be suppressed if somebody else paces the heart faster than them. So let us say if the VT pacing at 200 per minute and you pace the patient with a temporary pacemaker at 210, immediately the VT will abolish. So this is important. You can use it in torsades des pointes, which is like a chaotic. This is torsades des pointes. So you should immediately pace these patients. Specifically, there is a R on T phenomena. What is R on T phenomena? It happens in patients who have bradycardia. So let us say this is a patient who has a prolonged QT interval. So what will happen is sometimes the next QR, it falls on the T. The moment it falls, the patient heart throws a ventricular tachycardia. This is very important to know. R on T phenomena specifically occurs in bradycardia induced ventricular tachycardia. Bradycardia induced ventricular tachycardia. So this is very important. Then comes ICD. See, ICD is something that will be put at a later date. And many people get excited about putting an ICD in a patient who is having VT. Always remember, ICD is what? ICD is just a therapy. ICD is not a treatment or a preventive strategy for a ventricular tachycardia. For that, you need to give the patient medication only or revascularize them. Many people, they would just go on and putting ICD in a patient of VT. It will save them from a sudden cardiac death. But if you have seen a patient who has had a 50 shocks in a day, you would feel, why did I do it? Because these patients who are ischemic, they will continue to get shocks because they'll continue to get VT. And the battery of the ICD will be consumed within 25 days of putting the ICD. So it is so hell important that you give good amount of beta blockers, good amount of amiodarone to these patients so that they don't throw a VT. Yes, if you are putting the incidence of VT at least 1 or 2 times in a year, then putting an ICD will take that sudden cardiac death out of the table. But that doesn't mean that medications will not be required, because if you don't give any medication, this patient will continue to have shocks, like starting at 5 in the morning and then continuing till 5 next in the morning. So these patients will continue to have shocks. They'll say, doctor, either kill me or take out this device, because it's a DC shock that gives a thump every time the ventricle runs fast. ICD is not indicated in acute phase. The guidelines say at least wait for 45 days on maximal therapy, that is GDMT, which is goal-directed medical therapy. Nowadays, it is ACE inhibitor or angiotensin blocker or ARNI, along with this SGLT2 inhibitor, along with a good dose of beta blocker and a mineralocorticoid receptor antagonist. So once you have given these doses and the ejection fraction remains less than 35% at 45 days, that is the norm. That is when you put an ICD, telling the patient that, look, you have an ejection fraction of less than 35%. It's been 45 days that we've stented you. It's been 45 days that we've given you enough medication to recover, to help you recover from the condition that you were in. Still, your ejection fraction is less than 40%. So you need a ICD to save yourself from a potential ventricular arrhythmia anytime during your lifetime. But that doesn't mean a patient who is having regular VT that you put them on an ICD. That doesn't help anybody. It is an expensive proposition. It's 5 to 6 lakhs. And then if it keeps giving shocks, it will consume away its battery. So for that, nowadays, there is a defibrillator jacket available in US, not in India as of now. It will be available, but as of now, it's an external defibrillator. It's like worn as a jacket, like a bulletproof jacket, like a photographer's jacket, the safari photographers. So it's worn inside the clothes. So it's called a defib chest. That's vest, defib vest. That is, once somebody has an ejection fraction of less than 40% and they're not ready for an ICD, you can give them this vest option, because it is as good as a indwelling ICD. Is that clear? So these are the questions that will be asked there, and you will be responding to them confidently. So what is the role of magnesium in management of ventricular tachycardia or arrhythmias post-MI? So magnesium sulfate is indicated in torsades des pointes. It is the drug of choice for management of torsades des pointes arrhythmia, that is polymorphic VT with prolonged QT interval. specifically in patients with low magnesium levels. So people keep monitoring hypokalemia in these patients, but they forget that potassium is also kept in normal range with the help of the magnesium. So if the magnesium is low, then you are not able to, correct the potassium. So correct magnesium, the potassium will get corrected. What is the dose? It is 2 grams intravenous, undiluted over 5 to 10 minutes. So you need to give it as a slow bolus so that the arrhythmia can be prevented. But if the patient has torsades des pointes, then you need to give a IV short tuck, IV spontaneous bolus, fast bolus. It is fast, it is safe, and it is effective in QT, prolonged QT-related ventricular tachycardia. The drawbacks are it is ineffective if the QT is normal and can cause hypotension if it is pushed really fast. In case of a torsades des pointes, we are not concerned because anyways the patient will die because torsades is a very resistant kind of arrhythmia. It doesn't respond to amiodarone, doesn't respond to xylocard, it doesn't sometimes respond to defibrillation also. So magnesium is what corrects it immediately. So remember, if it is not a torsades des pointes, it is not a prolonged QT interval related ventricular arrhythmia, giving magnesium will not only waste the opportunity that you have to save the patient, but also can cause further hypotension in this patient. All right. Amiodarone, very good drug, broad spectrum, antiarrhythmic for VTVF, should be given in a patient who has been given a shock already. Dose is 300 milligram IV bolus and then 900 milligram by infusion over next 24 hours. That makes it a 300 milligram 8-hourly infusion. So 3 8-hour cycles should be given. That will give you 1200 milligrams of amiodarone, which is good enough to be loading dose, and then it can be tapered down. It is effective in ischemic myocardium and it is safe in LV dysfunction. It does cause hypotension, but not as much as magnesium or nitrates do. But yes, it was invented as a antihypertensive, and by serendipity, it was found that it prevents arrhythmias and treats arrhythmias. But as it was invented as a anti-hypertensive agent, so you should remember that although not much hypotension it will cause, but still, in a patient who has LV dysfunction, it is safe but can still cause low-grade hypotension. The only problem is that unlike magnesium, it causes prolongation of QT interval itself. So use it with a caution in patients whom already QT is prolonged. It can cause bradycardia, it can cause decrease in cardiac output because of bradycardia. So if you push it fast enough, it can cause cardiac arrest or hypotension. So you need to be very cautious there. It has to be given in IV bolus only in a patient who is undergoing a CPR secondary to ventricular fibrillation. Long-term toxicity is also there. So you need to take it with a pinch of salt. Thyroid-related, lung-related, liver fibrosis, all of them can occur with amiodarone. So you should try not to give amiodarone for a long term. Prefer going back to beta blockers, which are the standard of care these days in patients with poor ejection fraction. So there are certain points that I would like to reiterate for you. Number one, always correct potassium and magnesium early in shock patients because they can push the patient to a brink of myocardial arrhythmias. Use amiodarone after defibrillation failure or a success of defibrillation if the patient continues to have a non-sustained VT. But because amiodarone you are giving, you should monitor the QT interval. Do not rush for an ICD in acute phase. There will always be an option of putting an ICD in a patient's, CCS or CBS question in EDIC exam. It is a wrong answer. You should not opt for it. Emergency ICD is not indicated, recommended anywhere in any of the guidelines. It should not be given. It should be discouraged. Unless the patient is in electrical storm, even then it is such a chaos that the patient will ask for morphine.
If any arrhythmia is occurring within 24 hours of PCI, do not overthink. It is basically reperfusion syndrome, reperfusion arrhythmia which has occurred. All you need to do is treat them with utmost respect, treat them as and when they develop, and do not rush for an ICD. So this patient of ours, finally we got the tests back. Magnesium was low, 1.4 milligrams. We gave lidocaine, we gave amiodarone, the patient stabilized. Uh, the patient looks better again. Everybody takes a sigh of relief. But day 2, in the morning hours, the patient develops sudden acute pulmonary edema. The resident saw the echocardiography. In the previous echo, it was mentioned that the patient has a mild mitral regurgitation. But, but on auscultation, they found out that there is a new loud systolic murmur. The saturation now drops to 80%. Even on 10 liters of oxygen, now the patient is put on NIV. So what bedside clue will tell you that this patient is not in fluid overload? Number one, because the differential will remain. Why pulmonary edema has happened? Is it because of some mechanical complication, or is it any fluid overload? So we need to know what are the mechanical complications that happen after MI. We need to know what are the red flags on the echocardiography. So the patient has a saturation of 80% on non-rebreathing oxygen mask. The patient has new loud systolic murmur. Patient has an acute pulmonary edema, suddenly happened, and the patient is not responding to any diuretics or inotropes. What is wrong? I need to check. So this all picture of new loud pansystolic murmur radiating to axilla and sternum and chest full of crepes and saturation only 80% on full oxygen, not improving much on NIV support, sudden deterioration within 24 to 48 hours post MI, not responding to standard heart failure. This is a hallmark of severe mitral regurgitation that has happened acutely, and that can only happen secondary to rupture of the papillary muscles. If I have to draw it for you, it will look like this. This is the left ventricular cavity. This is the papillary muscle to which the mitral leaflets are attached. And what has happened is, bad luck, the muscle has ruptured, and this is now a flail mitral leaflet which is going up and down with the blood flow, and entirely whole of the cardiac output is going back into the left atrium and not going into the aorta. So this is aorta. So hardly any blood is flowing here. Everything is going back into the left atrium, leading to pulmonary edema. So what can you do? If pulmonary edema worsens rapidly, is refractory, there is a new murmur, always suspect a structural catastrophe, not pulmonary edema due to fluid overload. So what will you do? You will put an IABP in this patient. You will refer the patient to CTVS or cardiothoracic vascular surgeon immediately for a mitral valve repair or mitral valve replacement. Now, what are the other complications that can happen in a post-anterior wall MI patient? Classically, usually 1 to 5 days post-MI. Anterior MI can have a ventricular septal rupture, that is VSR, or a free wall rupture leading to tamponade and sudden death. And of course, LV aneurysm, that is a ballooning of the left ventricle. This is what happens. And there can be a clot in the left ventricle also. Inferior MI leads to papillary muscle rupture, especially posteromedial. Any MI can cause a LV thrombus. This is an LV thrombus, and a pericardial effusion or a tamponade. Any MI can cause that. Papillary muscle rupture is most classically associated with inferior MI, but that doesn't give you any respite in anterior MIs because multiple territories are usually involved. But classically inferior MI, and it is the posterior mitral leaflet that gets affected. What are the echocardiography findings which are red flags? Number one, flail mitral leaflet. Very important. A papillary muscle rupture You can sometimes even see it, clinically, that there is a flail mitral leaflet, and the LV is hyperdynamic. Why? Because now it is catering two exits. One is the aorta, the other is the mitral through
Left
the
atrium.
LA atrium. So one is aorta, the other is atrium. Now it is feeding two channels. So it is a hyperdynamic left ventricle. Severe acute MR, you can actually on echocardiography, on an echocardiogram, you can actually see a jet in the, a large eccentric regurgitant jet in the echo. So there is no LA-LV enlargement. Why? Because acutely the LA-LV doesn't get a time to adapt to the increased blood flow back into the LA. Acute MR, there is no time for any remodeling. Sometimes papillary muscle you can see floating with the blood flow. So that is usually, a very bad sign to see. And it is immediately then told that call the cardiovascular surgeon team immediately. This patient will need an emergency MVR. Transthoracic echocardiography, there's been a lot of hue and cry and about comparison between TTE and TOE. The problem is that a patient who is maintaining only 80% saturation on high flow oxygen mask and may require intubation anytime soon, of course, you're not going into the esophageal route. It is only for the patients who are stable enough who can be taken up for a transesophageal echo. Otherwise, we understand that transesophageal echo has a higher sensitivity. If you are at doubt and you're not able to arrive at a diagnosis, intubate the patient, have them lie down flat, and then put in a transesophageal echocardiography. So it's a big question of decision making. It does exclude VSR or flea wall rupture, but you have to keep the patient surviving until then. So the echocardiography in our patient, it revealed a posterior mitral leaflet flail with a torrential mitral regurgitation. This patient needs an emergency surgery. So you need to remember, you can take a photo shot of this. If the patient has a sudden dyspnea with a new murmur, always think of mitral regurgitation due to papillary muscle rupture. If there is hypoxia despite good amount of oxygen given, always consider flash pulmonary edema, then define the cause of pulmonary edema. If it is a refractory to diuretic, you know that there is a structural lesion that has gone bad, unless proven otherwise. Because if it is just a case of fluid overload and the urine output is pouring out, the patient should be responding to diuretics. If there's a new systolic murmur, immediately get an echocardiography. Transthoracic is always preferred. You can always get done a transesophageal echocardiography, but I always say do the TE in the cardiac operation theater. Don't do it in the ICU. Once you have made the patient sedated and surgery is being done, then you can put in a scope and see. If the echo shows a flail leaflet, don't wait for anything. No medicines will save this patient. Immediately intubate the patient, put them on an intra-aortic balloon pump if he is not already on them. Put on dobutamine. Why? Because dobutamine will cause systemic vascular resistance to drop. So the more blood will flow into the aorta, lesser will flow into the pulmonary system, that is through the mitral valve. It only gives you a small amount of window until the surgery is done. So these are all the features of acute MR: sudden dyspnea, murmur, hypoxia despite oxygen, refractory to diuretics, new systolic murmur, and a flail leaflet visible on an echocardiograph. Okay, so this patient was taken up for a mitral regurgitation. Now the mitral valve has been replaced. The patient returns to ICU in a very bad shape. The patient is on high dose noradrenaline, adrenaline, milrinone, and intra-aortic balloon pump. We did not expect much because this patient has gone through so much, only 25% ejection fraction, and then he developed a papillary muscle rupture, a mitral valve regurgitation, emergency surgery. Emergency surgery in an acute MI already carries a very high mortality, but then this patient has come back on high dose norepi, adrenaline, milrinone, IABP, everything. It's a tower-like situation. It's full of infusion pumps. So what is your plan now? How do you optimize the cardiac output? Do you consider a VA ECMO right away, or you want to wait for some time? What is the role of systemic venous oxygen saturation and a mixed venous or a central venous oxygen saturation? Lactate, what trend will it help to us to come to a conclusion? So what is the plan to optimize cardiac output in this patient? See, the main priorities are to get the urine out of the system and maintain a good preload, titrate the vasoactive support based on perfusion. You don't want to cyanose the patient only because of vasopressors. Fill up the patient, give enough fluids, then keep monitoring the mixed venous oxygen saturation, keep monitoring the cardiac output, have a Swan Gans in place, monitor the pulmonary artery circulation, a cardiac index, a cardiac output, and of course, lactates. And then titrate the vasoactive substances downwards. Don't titrate them upwards, because if upwards, then you need an ECMO. Rule out any surgical complications like a tamponade or a pleural hematoma or a blood loss or a vasoplegia secondary to pump. The patients who are taken on a heart lung machine, they sometimes have a pump vasoplegia. That is, when they are coming off pump, then they develop vasoplegia that responds only to vasopressin, high dose. So rule it out. Then stepwise, get an echocardiography done to assess the left ventricle size, function, RV's performance. Rule out tamponade. Why RV performance is important? Because if RV is also failing, then IABP will not help. In a patient of post-MI, if the RV, right ventricle, has failed, then only IABP can save the patient. Oh, sorry, only ECMO can save the patient, VA ECMO. IABP will not help because IABP can only help the left ventricle. If you need something to help the heart as a complete, then you need ECMO as a good device. So assess the left ventricular and right ventricular function both. Rule out tamponade, effusion, prosthetic valve dysfunction. Get a good amount of volume status, like optimize the preload, avoiding fluid overload, get an CVP, echo, try to do a fluid challenge test with a passive leg raise, fine tune the inotropes. Milrinone is a good one, but after 6 hours to 24 hours, it produces lot of lactate. So it does cause afterload reduction and inotropy, but increases lactate. So try to get it down. Consider weaning off adrenaline if there is tachycardia or rising lactate. So whenever you in the exam, you will be asked which two drugs increase lactates despite being vasoactive drugs. One is milrinone, other is epinephrine. So you should try decreasing them both as fast as possible. Norepinephrine is an excellent drug of choice in cardiogenic shock. Keep it on. Keep the mean arterial pressure above 65. So whenever you have doubt, multiple inotropes, always wean off all other vasopressor inotropes first and norepinephrine at the end. If high lactates continue, then you should consider escalation. Escalation means going for VA ECMO, means you are not able to get the shock out of the picture. Mechanical support, IABP does augment coronary perfusion, reduces afterload, but if not helping, move to VA ECMO. Yes, this is the point where you actually escalate. What are the indications? Refractory cardiogenic shock, despite 2 inotropes and IABP. So now is the time when you should switch to an ECMO. And there is a good evidence of end organ hypoperfusion. The lactates are rising and the mixed venous or central venous oxygen saturation is low. Not improving or worsening. Can anybody tell me why mixed venous or central venous oxygen saturation is low in a patient of cardiogenic shock? Quickly.
Utilization of the blood by the brain will lead to the decrease of the mixed venous saturation.
So, yeah, correct. So basically, it is the stasis, it is the slowing down of circulation. So the venous blood stays for a longer time in the cellular periphery, in the peripheral circulation. So the cells will take off all the oxygen which is present in the venous blood to replenish themselves. And because the sluggish blood flow is there, they will keep taking it until the next blood comes to circulate them. So eventually the venous saturation will fall. What are the benefits of ECMO? It is a full cardiopulmonary support. It will support the right ventricle also. IABP will not do that. It allows myocardium to rest. So it is a very good bridge to recovery. What is the bridge concept? I've already told you, either for a definitive surgery or bridge to recovery, if myocardium is likely to improve, or you're planning for a transplant of myocardium at a later date. ECMO should not be delayed. This is a pearl that you should remember always. Once you've diagnosed that the patient has a refractory cardiogenic shock, means 2+ inotropes have been given, you put an IABP. If 2+ inotropes plus an IABP is not working, what next? The lactates are rising, venous saturation is decreasing. What next? Immediately, you should know that ECMO is needed. What role do SVO2, SCVO2 and lactate trend play here? So these are real-time perfusion markers. You should never ever ignore them. SCVO2 more than 70 is good and healthy. If it is low, we understand that there is a poor oxygen delivery, decreased cardiac output, increased extraction is happening. SVO2 should be more than 65. Again, it is a true mixed form. You need to get it from the PA catheter. If you don't have, you only have a central vein, then all you can get is SCVO2 because you cannot get the mixed venous oxygen saturation. Then is lactate. Anything less than 2 is the target. But if it continues to rise, it only tells us that glycolysis, Krebs cycle, anaerobic metabolism is happening. And also catecholamines, epinephrine, milrinone, both of them can be contributing. Okay, so lactate uptrending is bad, consider ECMO. Mixed venous saturation, again, consider upgrading. SCVO2 rising towards normal, it tells you that the patient is getting better. Whatever you are doing, keep doing it. Low SCVO2 rising lactates and failing inotropes, you need to put the patient on ECMO immediately. In our patient, despite maximal support, MAP was 58, lactate was 6, patient is cold, patient is oliguric, patient is now refractory cardiogenic shock, post MVR, this patient needs a VA ECMO. VA ECMO is put. So what you need to understand is echo plus perfusion markers like lactate, mixed venous oxygen saturation, central venous oxygen saturation, they are the markers that guide the escalation of therapy. Milrinone and norepinephrine is a common combo post mitral valve surgery, but lactate rising is a problem. IABP can help temporarily, but may not be good enough. ECMO is not the last resort. It's a timely decision. Always think that it can save the patient. Heart transplant is the last resort. Always evaluate to correct any post-operative causes. Don't have an anchoring bias that this patient is gone into cardiogenic shock only. Try to see if there is anything else contributing to it, probably sepsis, maybe prosthetic valve dysfunction or tamponade. At the same time, these patients can have a different outcome. Not all of them will survive. You wean off the sedation, there is no response. Pupils are sluggish, liver function test, ALT is 1800, creat is 3.9, platelets are dropping 60,000. You know it's a lost battle. I will leave you to few questions for yourself. What is the neuroprognostication pathway after cardiac arrest and ECMO? This is upcoming. Everybody is asking these questions in because the ECMO is increasing and sometimes patients who are brain dead are kept on ECMO. So you need to be very, very clear that this question will be asked in the exam. What is the neuroprognostication pathway and how do you approach it? When to limit or withdraw the care? When do you say we've done enough? Now, if the patient is not surviving, let's call it a day. Is this MODS due to ongoing ischemia or ECMO-related complication? This is a question that I will address for you because it's more of a technical question, that whether this multi-organ dysfunction like liver failure, renal failure, is it because of an ongoing skin side? So MODS in an ECMO-supported post-MI patient, very important. Rising creat, LFT trending up, worsening oxygenation, low GCS, coagulopathy, maybe deranged INR, deranged platelet count, and lactates climbing again. We have to follow a structured approach to drive the differential. If it is an ongoing ischemia or a primary cardiac failure, that is, cardiac output not being maintained despite the patient being on an ECMO, it will be suggested by a poor LV recovery. That means ejection fraction continues to be either same or poor. For example, in our case, if it drops down to 10%. No pulsatility in the circulation despite ECMO. Remember, ECMO doesn't give a pulsatile blood flow, it's a rotor pump. Persistently low mixed venous saturation, no reduction in vasopressors, lactates keep on rising, mottling happens, and patient has a GI bleed. I'm sorry to say, this patient is going to die. If there is an LV distension, which can occur as a consequence of VA ECMO and impairs recovery, you should immediately drain out some blood from the venous end so that the preload can be decreased. So these are ECMO-based questions. Then prosthetic dysfunction of mitral valve, and of course, residual coronary artery lesions can be there. You should always check for them. If it is an ECMO-related complication, then you should know all of them. It can happen in CNS, that is, embolic stroke can happen because of an improper anticoagulation, or a bleeding can happen in the brain, intracranial bleed. Lungs, Harlequin syndrome, that is a differential hypoxia, one lung well ventilated, other lung poorly ventilated. So hypoxia on one side, blue on one side, red on one side. So it's called a Harlequin. Then pulmonary hemorrhage can happen secondary to this DIC. Hemolysis, DIC, thrombocytopenia, all due to blood flowing through an external circuit can happen. Renal dysfunction, hemodynamic instability, AKI. This is a very, very common problem. So CRRT can be connected. And then circuit-related issues like clotting, air embolism, sepsis, all of them can happen. What are the red flags in ECMO-related mods? Number one, hemolysis, rising LDH up to 2,000-3,000 I have seen. Free hemoglobin in the circulation because of extensive hemolysis, pink-colored urine. Cannula issues, malposition, recirculation, septicemia, all of them I have seen. Infection can happen, and differential hypoxia, of course, this is not a very common thing, but does happen if the LV balloons out and does not lead to oxygenation of cortex and brain, and of course the lungs get partially ventilated. So there are alternate endings for all of you. You can all just take a route different from whatever has happened, and the climax can change. For example, this patient can have a miraculous recovery. After ECMO for 5 days, he stabilizes, weaned off, extubated, discuss rehab strategies, secondary prevention, and maybe an implantable defibrillator. Or you can reach to an ethical crossroad where patient has been confirmed for a brain death with all the mods, or maybe organs are stable and you discuss organ donation, or borderline functionality, persistent organ dysfunction, but patient is not recovering. What defines futility? I will leave you with these questions. So you must remember mods post ECMO. Nowadays, earlier it was only till ECMO, now it is mods after ECMO, which is being discussed. Echo ABG's lab, circuit review, everything you should be keeping on your radar. Avoiding ECMO trap, that ECMO is the last resort. No, it is not the last resort. It is by far, and it's a therapeutic option that you should always give to anyone who has a possible recoverable cardiac condition. If myocardium does not show any recovery, you should start the goals of care discussions early with the patient. So I hope the class was useful. So we will have few questions. I would like you to contribute, all of you. Which MI complication typically occurs 2 to 5 days post MI and presents with a new murmur and shock? Yes?
Papillary muscle rupture.
Wonderful. What is the most common cause of death in acute myocardial infarction patients? So in patients in whom, yeah, correct. In patients who have not been
What did she
stented,
say, sir?
say again?
What's the most common cause of death in acute MI patients?
I was going to split it into two. One is, if you cannot reach the hospital, you die of a ventricular fibrillation due to an unopened vessel. If the patient reaches the hospital, gets a primary PCI, still can die of a ventricular fibrillation because of reperfusion arrhythmia. So either way, it is going to be ventricular fibrillation. A VA ECMO is best indicated when
Refractory cardiogenic.
Refractory cardiogenic shock.
So when there are 2+ inotropes and an IABP and the patient is not recovering, that is defined as a refractory cardiogenic shock. Which inotrope increases myocardial oxygen demand the most?
Vitamin.
Dobutamine.
Adrenaline.
So it has to be adrenaline. And then what echo sign suggests a ventricular free wall rupture? I'll give you answers to all of them. So which MI complication occurs 2 to 5 days post MI and presents with a new murmur and a shock? Answer is VSR, although papillary muscle rupture can also present with the same. But usually if the patient has a mitral valve and a papillary muscle rupture, it will lead to pulmonary edema, shock, may or may not be there, but a VSR patient will always be in a shock. Sudden pansystolic murmur will be there. Biventricular failure occurs because of the free flowing blood from RV to LV and LV to RV often occurs after anterior wall MI. What is the most common cause of death in acute MI patients? It is ventricular fibrillation. Of course, pre-MI, post-MI, before any intervention is done, they can die of VF. Even after stenting, they die of VF. A VA ECMO is best indicated in refractory cardiogenic shock despite maximum IABP support. Use it when patient has a low output, cardiac output, and an organ dysfunction. Should not delay ECMO ever. Which inotrope increases myocardial oxygen demand the most is epinephrine, causes tachycardia, increases afterload, and there is a lactate surge. Useful short term in post-arrest situation, but not for continuous treatment. In cardiogenic shock, always prefer Dobu, Milry, or levosimendan. What echo sign suggests ventricular free wall rupture? Presence of pericardial effusion, tamponade signs, Beck's triad, as one of the doctors said, and there's a wall discontinuity. You can actually see a rupture. Look for RV collapse, swinging heart, echo dropout in LV wall, urgent pericardiocentesis. Put in a pigtail and get a surgical consult. Usually patients die. We lost one recently. Despite ECMO, the patient did not make it. So key revision topics for you all. Number one, you have to have a timeline of MI complications and don't confuse VSR with mitral valve regurgitation, because in MR, it is usually pulmonary edema, but in VSR, it will be shock and pulmonary edema and hypoxia. Comparison table for all the shock types: distributive, septic, hypovolemic, and cardiogenic. You should remember them by heart. Whatever happens to the heart rate, stroke volume, JVP, SVR, pulmonary vascular resistance, everything, cardiac output and index. What are the indications of ECMO and contraindications, and what all happens as a complications of ECMO, because ECMO is increasing now? What are the algorithms for post-MI arrhythmia management? Very important for you. Thank you so much for your patient hearing and contributing to the class.